Apparently I have to stand over here. So, ladies and gentlemen, I'd like you all to think about what you like doing that's not to do with medicine, something that's important to you, that is something that takes you out of your job. And I guess I hope for all of you, the thing that's really important to you is family, friends, etc. But not that. Something that you actually do. It might be an intellectual activity. I like playing golf. I play quite a lot of golf, and I'm lucky my 3 sons play golf. Professor Myberg, who's down here at the front, I know likes to row and likes to play the guitar. So think about what you like doing and what impact would it have on that were you to get severe sepsis and spend some time in an ICU? Would you be back to that in 6 months or a year? Have a think about it, and we might get back to that later. So, sepsis is in some ways, I'm not sure these will stand up on their own, so I'll have to either lean on them or no, it's all right, people, I might lean on them. It's a bit unsmack, not walking about and all that, but I'll just lean on them. So sepsis is a bit like, beauty. We all know it when we see it, but it's quite hard to define. But this is obviously how I think about sepsis, is someone in my ICU, attached to a lot of machines, treated with a lot of drugs, etc. And although we might argue about whether this is exactly right, this paper that came from the ANZIC's core database, the data from around the world is that the mortality rate for sepsis is decreasing. So more people are surviving sepsis. And that means that we now have to, and belatedly I think, because we haven't really thought about this, we have to actually think about what is happening to the people who are surviving their sepsis and we're kicking out of our ICUs. Now I'm going to go and lean these over here. So Derek Angus called this a hidden public health disaster. So they should stand up there, Pete. If they fall over, take care of it. Thank you. What are the possibilities? What could be happening? And Derek was very kindly, some of these are his slides, and he was very happy for me to use them. So this is current care. We have this number of people fully recovering. Already we have recognized people with severe morbidity surviving, and then we have people dying. And if we reduce death, we might have far more people with the full recovery. That would be fantastic. Same number of people with significant morbidity. Or do we have the survivors, the people who are now surviving, they have significant morbidity and the same reduced death? Or worse still, could it be that something we're doing, and I think this is extremely unlikely, is that we're having more survivors but actually more with significant morbidity? That's relatively unlikely. So what do we know about life after sepsis? Physical disability is common, and sometimes it's bloody obvious. I mean, you don't have any difficulty seeing that Corinne has significant disabilities as a result of sepsis. And we'll have a bit more about and from Corinne later. What people don't know about is the long-term impacts that are less obvious. So this is a very nice paper from JAMA about there is a prevalence of moderate and severe cognitive impairment is increased by 10% over matched controls, etc. There's a very high rate of new functional impairments. So we think we've made people better, we send them out of the ICU, but it's only very, very recently that we've started to gather data on how they are afterwards. And these declines in cognitive and functional ability, they persist for at least 8 years. We don't have a lot of longitudinal data that informs us on exactly what it is and how long it lasts. And this is certainly an area that an increasing number of people, including our group at the George Institute, are starting to realize we need to research this, because this is a big deal. This is a paper out of JAMA, and this is actually a really nice study, because the trouble we have with trying to understand what has happened to people is that we don't have a good baseline. This is a big problem for us, because we know that the major determinant of how people recover after ICU, not surprisingly, is what they were like before they went into the ICU. That should not be a big surprise. If you couldn't walk before you went into the ICU, it's relatively unlikely you're going to be able to walk when you come out again. So this study is the health and retirement study from the US, which is people over the age of 65 who, at 6-month intervals, their health is assessed. So this is a fantastic study, and we've got a similar sort of thing in Australia called the 45 and up study, which is longitudinally following a cohort of people, and you can then look at how things impact their health and the health service use, etc. So what this study shows here, so these are the patients in the second survey they took before they had sepsis, and this is the second survey they took after they had sepsis. And the yellow is the cognitive impairment. I can't actually read that. Can you read it? It's pretty blurred, isn't it? That's a shame. I'll have a word with Derek about that, because he gave me some crap slides. I'm going to put my glasses on now, and that will... Yes. Yes, that's going to improve matters. Okay, mild. Okay, thank you, Professor Maitland. Mild cognitive impairment, moderate to severe. And you can see this is the survey immediately before these patients had sepsis, and afterwards there's a big increase in the number of patients who have got moderate or severe cognitive impairment. Now that, to me, it's interesting, because we've been studying, and other people have been studying, and in Canada, Professor Brindley, there's been a very, very nice study asking patients, what are the outcomes that are important to you when you come out of the ICU? And it asks, the study asked people, if you were to receive a treatment that increased your chances of surviving intensive care, but you would survive with cognitive impairment, would you wish to receive that treatment? And a very high percentage said no, that being cognitively intact was more important to them than survival. And we don't consider that, and maybe we're going to in the future. So, if we look down at this graph, and you'll be pleased to know that this is pretty much the only data this talk contains. The little red dots, these are the people who have no limitations at baseline, and the blue ones are the ones who have mild or moderate limitations at baseline. And you're not surprised that those who have severe limitations at baseline after they've had sepsis, there's a high proportion who are not doing well. But even the ones who were very good beforehand now have problems, and this is the median number of activities of daily living in which they're impaired, okay? So this is physical impairment. So these patients who had no limitations in their activities of daily living, so they could go out and play golf, they've now got, on average, about 2 activities of daily living in which they're impaired. And obviously, the blue ones, who are reasonably good, they've got 1 to 1.5 as a median number of activities of daily living with impairment. They're now up at 4 or 5 after their sepsis, at 1 year, 3 years, and 5 years. So you can see this has persisted over a period of time. And this is relatively novel information. I think we need to think about this when we're treating our patients. And there are some very obvious questions that I'll come on to. So that's pretty much most of the data. This is about neurocognitive defects. So asked to copy the above picture. I was a bit worried about this because I've done this. I've done one of these. I'm not sure I scored that well. Near normal rendition by an unimpaired 69-year-old. Pneumonia survivor. Severely impaired ARDS survivor. You can see these sorts of tests that are now demonstrating to us that there is some severe problems in patients who've survived sepsis. And if we've reduced sepsis mortality from 50% down to 25%, we really have got to pay attention to that other 75%. Because until very recently, we haven't. Pretty much all our trials, and they still are, and mortality is still a good outcome measure. You want people who die, you want to stop that. But we've really got to pay attention to these people who survive. Now, the interesting question to which I don't think we have an answer, is this what has been called post-sepsis syndrome, just post-intensive care syndrome? So if we take patients who've had sepsis and we take other patients who are in the ICU for some other reason, and we have some marker of severity of illness and length of time in the ICU, etc., is there something particular about sepsis that has a worse prognosis in terms of long-term outcome than what the SCCM and others have termed the post-intensive care syndrome? And I don't think we know the answer to that yet. And that's an important question to answer, because we do know from some work done by David Menon and others in Cambridge. They have this wonderful sort of functional MRI and structural studies of the brain, that the brain structurally is altered by sepsis. Now, we don't know yet whether that's peculiar to sepsis or whether it's something that is just post-intensive care. So that's an area for ongoing research. But we do know that people who've had sepsis have long-term bad outcomes. So I'm going to let Corinne, who I have never met, but I talk to, because she lives in Queensland, I'm going to let Corinne tell you something.
An illness in late 2012, and I contracted septicemia, which led to the amputation of my legs, and so I lost my legs in October 2012, and then my hands in the end of November. So it all happened very suddenly, but we had to make the decision to amputate my legs to save my life, and then my hands unfortunately died off, so they had to be amputated as well. So it's life-changing, but I went through 5 months of pretty extensive rehabilitation to try and return to some form of independence and start walking and just get moving again. I was always focusing on the future rather than dwelling on what had actually happened. My whole life changed, and I was trying to just be as independent and determined as possible just to make the most of life, and that's why I very quickly wanted to start walking again, and then regaining my fitness and focusing on my health and well-being and just get moving again.
Nice shot.
Look at these guys, love it! Yes, I have bad days every now and then, but Craig's humour is usually one thing that gets me out of it, so he's very quick to sort of make light of the situation, and I think humour has been an absolute saving grace.
Given that her surgery was only a couple of years ago, it's been amazing to watch the speed at which she's effectively reclaimed her life. So that's the stuff that inspires me more than anything.
So there's a lot of information in that 2 minutes, less than 2 minutes. I trimmed that down. You can go onto her website and that's freely accessible. And we did some editing with the very clever people that they have here who helped me edit that, because I couldn't edit a video. There's a huge amount of information in there. 5 months of rehabilitation to get her back on her feet. I mean, did you notice the muscle wasting when she was, when she was on that walker there. Look at that. I mean, that's amazing. I mean, this is the sort of stuff that we've got to try and work out how we prevent this in our patients. We've tried all sorts of crazy things like growth hormone that kill people and so on, so we don't know. And the guy at the end who's from this charity that actually helps people who are impaired, who have limb loss, etc., in low-income countries, saying it's only 2 years since her surgery. 2 years. It's a huge, huge burden. As I said, this is so obvious. This is very visible. And the other picture here is another lady who is called Karina. I know it's Corinne and Karina. And I was asked to go and speak at a fundraising event for her in Southern Highlands of New South Wales, because she's a young lady with a young family who's lost her limbs through sepsis and needs money. Now, we actually have services for these people. It's obvious there's a problem. Everyone can see there's a problem. They've lost their limbs, they're young mothers, it's tragic, and they get support. There is no coordinated service, and I'd be interested to hear if there is one somewhere else in the world, but certainly in Australia, there is no coordinated service of post-sepsis care. We discharge them from the ICU, and the problem is we can discharge them to the care of anyone. They may have come in with pneumonia and they go back to a respiratory physician, or they may have come in with perforated bowel, and they go back to a GI surgeon. They may have had a gallstone pancreatitis or something and end up with a gastroenterologist at the end of the day. They can go to anyone. Nobody owns this disease, and that is, I think, one of the reasons why there is no coordinated post-sepsis care program. And I think we need that. It's something I'm trying to get some interest in doing, which is why we need to understand and have data. I need to be able to go to policymakers and politicians and say, there are X numbers of cases of sepsis in Australia. This is the long-term cost and use. And there's Hallie Prescott and Jack Washener's group at Ann Arbor have just published some papers about the increased mortality following sepsis and the vastly increased use of healthcare services. And if I can get data on that, I can convince my politicians that this is costing you, because they think our money that we give them through tax, they think it's their money. This is costing the country money. We need to do something about this. And the incidence of sepsis with age goes like that. So as our populations age, the number of survivors we're going to have and the impact on that on our healthcare systems is going to be enormous. So we're scratching the surface at the moment, but hopefully we're going to develop a more coordinated approach to this. We're at very early days, and I think it's absolutely essential that we don't just feel that when we kick people, those of us who work in ICU, when we kick people out of the ICU, that's not the end of the job. Because there's two things we need to know that we don't currently know. Well, I think there may be more than two, but I'm going to focus on two. And that is, what can we do in the emergency department in the very early research? I mean, in the emergency department, most people who die of sepsis come in through the emergency department. They don't acquire it in a hospital. So does early treatment, early recognition, early treatment there not only reduce mortality, but reduce long-term morbidity? That makes sense. In the ICU, what can we do in the ICU differently? We are all focused on early mobilization, minimization of sedation, trying to prevent delirium, limit it, etc. Those things make sense because they're associated with these bad outcomes, but we don't know that changing them is going to improve matters. So we need to research that. And then the second question, if I said there's two things, what can we do in the hospital to stop it? What can we do afterwards to ameliorate it, to make it better, to reduce this terrible burden on people? Now, if someone's lost their limbs, I'm not sure we're going to be able to do that. But maybe if we treated it different in the ICU, they might not have had quite so much tissue loss. We don't know. Those are the things that we need to look at. So I just want to leave you with the idea, the realization that we shouldn't pat ourselves on the back once we throw someone out of the ICU who survived severe sepsis. This is just the beginning of a long road for them. And we need to better understand what that road involves, and we need to better understand how to get them down that road and in better shape at the end of the day. Thank you. What do we do now?
Thanks very much, Simon. I just had a question before we go to Twitter. What do you think the role of ICU follow-up clinics is in helping people manage any symptoms they may still be suffering after surviving sepsis in ICU?
There's no data that they improve outcome, but I can't believe that's true. You know, when I went and sat in, I'm sorry, I'll tell you an anecdote. I'm not supposed to believe in anecdotes, but there was a young lady who came into the clinic with her husband, and she'd had a peripartum myocarditis. She'd had twins, and she got severe heart failure, and she arrested as the ambulance crew were loading her into the ambulance. And she ended up on ECMO, and she got through all that, and she went home. And she was sitting on this chair in this clinic, and she was answering, "Oh, no, everything's fine, you know, we're doing well, and my heart's okay, apparently." And her husband was all twitching on his chair, and eventually said to her, "But you have bad days, don't you?" And she said, and then it all flooded out of her, that although she'd been told her heart had a number of 40%, which presumably was left ventricular ejection fraction, she was absolutely petrified that if she missed one of her tablets, she would have a cardiac arrest and drop down dead. She didn't know, she had these she had twins, and she was petrified that she was going to drop dead if she missed one of her tablets or didn't do exactly what was done, the doctors had told her to do, and then these two twins would be motherless and on their own. And I have no doubt that her life was improved by going to that clinic, because we were able to, you know, say to her, I wasn't treating her, but, you know, the other people say to her, explain to her, and that sort of thing. Now, that's very hard to measure, because the current data says that ICU, post-ICU recovery clinics have no impact on any measurable outcome. I'm not sure that's the case. I think maybe we haven't structured. Have we structured the clinics properly? Are we measuring the right outcomes? Lots of, again, early days. So I think we as clinicians have a responsibility, just as we would expect a surgeon to see a patient after they've had an operation. ICU is worse than an operation. It's why we ought to get consent to people coming into the ICU. You know, in some ways, you know, it's a long, horrible business, and yet we kick people out and we don't follow them up. And I think that's inherently a fault of some of us, including moi.
Great, thanks, Simon. Chris, what do we have on Twitter?
Well, on a related note, someone's asked how on earth we can use this information on cognitive decline to consent people for critical care.
So there's people, I'm not sure if the gist of the question is if we're going to tell people don't come into intensive care because if you do, you're going to be really bad when you come out the other end. I think my take on that, and I'm not sure if I've got the question right, is that we need, and I was fascinated yesterday with Alex's pro-con on cardiac arrest and so on, because what we need to, you know, the ideal shared care paradigm, etc., is that we sit with the patient. Most of our patients are unconscious, which makes it a little bit tricky. We sit with the patient and we say, these are your treatment options. These are the likely outcomes. I would recommend this, but this is another option if you prefer that, because that outcome is unacceptable to you. Because I can't tell you what is acceptable to you, only you know what's acceptable to you. So ideally, in order to do that, we have to have much better information about what the likely outcomes of those choices are. And when we've got that information, and if the information is, okay, you know, if someone said to me, my father's just turned 90, he still plays a bit of golf, but not quite as much as me. And if someone rang me up, because he lives in Scotland, and said, your father's got profound severe sepsis and, you know, needs to be intubated and go into ICU and have the whole kit and caboodle, I'd said, don't do it. Because I know what he's like now, and I know what that would do to him, and I don't think he'd want it. But we need to, you can't advise people on what treatment options you think are right for them, or giving them even the options, unless you actually know with accuracy what those outcomes will be. I think that's step one, to actually understand And we're only scratching the surface on long-term outcomes of critical care, let alone sepsis.